Good morning, everyone. How's everyone doing today? I hope everyone is doing well. Yes, you've traveled far. I'm originally from Southern California. This is like next door. It's LA freeways, but I do appreciate the patience here for everybody. And with the last minute change of venue that occurred, you all really clearly wanted to be here. Maybe we were testing you a little bit, but you passed the test, which is great. I want to welcome everybody, and really I want to especially welcome our committee who has helped put this together. We have Dr. Derek Smith, who's a clinical professor emeritus at UBC, Dr. Paul Devlin, Blair Gibbs, a former UK policy advisor who's now in Vancouver, Dr. Julian Summers, John Clarides, and many, many others. I also want to thank the provincial leaders that are here or will be here. Today, we are lucky to be joined by the Assistant Deputy Minister for Mental Health and Addictions, Alexandra Butler, so thank you for being here. We will be soon, if not already, joined by the Leader of the Opposition, Kevin Falcon, as well as Leader John Rustad of BC Conservative Party. I want to thank the municipal leaders that are here, including our next speaker, which we're all very excited to hear from, thank you, including Mayor of Port Coquitlam, Brad West, the acting deputy mayor of Vancouver and a Vancouver councillor, actually the deputy mayor, not acting, Peter Meisner, and some Vancouver councillors who are with us, Mike Klassen, Brian Montague, also some Surrey councillors with us, including Linda Neese and Richmond councillor Chuck O, and several former elected officials in the audience as well from various cities who have actually done some really innovative work that I'm just learning about here today. I also want to acknowledge the Executive Director of Vancouver Coastal Health, who's also here to join us, Miranda Compton. Again, as I was saying earlier, I want to thank you for your patience and understanding here. I think the move here and kind of the chatter that's going on that we're not, obviously we can't ignore, is actually emblematic of the problem that we're facing and the problem that many of you are facing. And I've talked to, whether it's physicians at Vancouver General Hospital who, when speaking the truth, have to sometimes do so in fear if they sort of deviate from the norm, or whether it's people running recovery centers out in the islands like Bowen Island who working hard to counter sort of the mixed messaging that their youth are feeling, whether it's where I was so lucky to go up to, we're going to hear later from Bill Yoakum, but I was so lucky to go up and see what he was doing in Kwat-Lelum out there with the new treatment center for Indigenous youth. I think the lack of the open dialogue is a problem, and that's kind of one of the things why we're here to try and change that. And really a lack of listening to one another, and sort of this interesting reflex that as a somewhat outsider, although I'm now, I guess, an insider, I'm here now, is sort of this reflex to pit sides against each other. This reflex of sort of one party versus one, harm reduction versus treatment, prevention versus recovery, yes law enforcement, no law enforcement. These false dichotomies that unfortunately have totally dominated this discussion as the body count has mounted to levels that when I saw after being here for how long I've been here and studying in this field for over 25 years, where I couldn't believe when I saw the numbers that I'm about to show you, and you're going to hear more about from our illustrious speakers today. So we've come together here at Prosper, and this is our very first meeting, so I apologize. We're going to mess up. It's clearly not perfect. We already started, 45 minutes late. But we've really come here to break down these false dichotomies, and in many cases dispel the cloud of fear. The cloud of fear that many people working in this field and wanting to speak out are dealing with every day as they're trying to, by the way, save lives. And really promote this apparently radical idea that drug addiction is a preventable, treatable disease, and that everyone can recover, and as people in recovery love to say, live a life beyond their wildest dreams. That's what we're all about. Let me tell you what we're here not to do, lest you may have heard some things. We're not here, we're not funded by the private treatment sector. In fact, we're funded by many of you paid to get in, and we appreciate it, and I hope you're getting $99 worth of energy bites in the back. I hope you do that. We're not here to privatize healthcare. I can tell you as someone who got a $30,000 bill for a dislocated shoulder 25 years ago, and 100 OxyContins, by the way, thrown in. We're not here to do that. And as someone, and you're going to hear, we're so excited, and you need to stay till the end. Best for last, I can say, is my colleague Keith Humphreys that I've worked with for so long, and learning from him in the first year of the Obama administration and putting together the Affordable Care Act, which ensured overnight 62 million people to get drug treatment. That had never happened before. But we're not here to promote a sort of privatization of that. We're not funded by law enforcement, nor are we here to promote the idea that we could ever arrest our way out of the drug problem. That's falling into the default dichotomist trap. Nor are we here to promote this party's agenda, that party's platform. Every leader has been personally invited, actually in person. We've been lucky to have an audience with each of the leaders in person. They know what we're doing. They have done their best to be here. We appreciate what each of them have done and what they continue to do. And we really refuse to be caught up in sort of the partisan mess that sometimes, unfortunately, this issue has been used for, frankly, on all sides. We're really here for one reason, and that reason is to help decision makers and the public navigate this complicated issue with common sense, evidence, empathy, care, toward the goal of prevention and recovery. So really, who are we? I mean, when I found myself here in Vancouver, actually here in Richmond to be, so it's pretty apropos that we're back in Richmond. This is where we came, not just for the airport. I actually lived in Richmond in the beginning. So it was a bit by design and a bit by accident 4 years ago, the day the pandemic, it was the day before the pandemic closed the border. In fact, our flight was the last one where the captain came on and said, anybody wanting to go skiing, you're gonna have to turn around. Whistler is now closed. There was a collective groan. Again, I was not only sort of astounded by some of the numbers that we are seeing, but really, when it comes to the numbers of overdoses, I was frankly astounded that we kind of keep doing a lot of the same thing with some things on the corners that might be different, but we sort of keep doing the same thing and expect really a lot of different results. Frankly, whether that's in the province or whether that's in the country as a whole. And it seemed very clear to me that we really needed to think about systems-wide change. By the way, the last graph there showing that we are on track to outpace. So I wish I could say it went down in that year, but it didn't. And so this is, when you look at BC and Canada, we're on track to increase. I think it's very concerning, and the numbers don't lie. When you look at the way that we are here in the province compared to industrialized countries around the world, various regions around the world, whether it's the Middle East, Scandinavia, parts of Europe, and even the United States, which is traditionally, probably the most famous book in drug policy is called The American Disease, and that was by the late Dave Musto at Yale. And it was because, unfortunately, America always had this badge of being the highest, usage in the world. We actually, that gold medal has been passed over to you all. And that's not one that any of us would wear with pride. That's one that should be a wake-up call, that doing the same thing over and over again and expecting different results is something called insanity. And we need to figure out what else we can do. And then I think these numbers are pretty astounding. So the disproportionate level of the way we see overdoses here in the province versus the population is something that's alarming. The disproportionate level that we're feeling in our Indigenous communities, whether you do a qualitative sample of the downtown east side or whether you do run the numbers with people like Bill or others, is something that it should be alarming us. The impact is not just on the individual. I think we think about that a lot, but I think we're also we need to be thinking about the impact on other people, whether it's family members, whether it's children. This quote by the BC's representative for children and youth, I think says it all about kind of where we are. And, obviously we've had a change in the game since the fentanyls arrived. And when we think about, 2016, but it's not like there wasn't a problem before 2016. I mean, you sometimes hear a bit of a fetishization of, man, if we could only go back to the year when we had only doubled our overdoses instead of tripled prior to 2016, when we only had quote unquote clean heroin and methamphetamine. And I think we need to do better. So, what has been our response? Obviously, Vancouver pioneered something that was, in many ways, a shot heard around the world, and in many ways, a very smart, progressive way to think about drugs and to think about it in a balanced way with obviously the 4-pillar strategy. We're very lucky to have former Councillor Lynn Kennedy with us here today, was one of the architects of that, along with obviously Mayor Owen and others. But for whatever reason, we have seen the pillars, in my opinion, I guess, sort of fall apart, with the exception of pretty much one emphasis. And that is not an emphasis, that is not something that we want to say we don't need. But when you only have one pillar, it's hard for the structure to stay up. We absolutely need, let me be very clear, we need harm reduction. It has to be a part of the approach. But we have to invest in the other pillars as well, and I'm not saying that hasn't been there. We will give credit where it's due. But we have to understand we need a balance to prevent the roof from collapsing on top of our heads. I think it's abundantly clear that roof is collapsing right now when you look at the numbers. So, I mean, what is harm reduction? At its best, and I'll focus at its best, because we're optimists here, it is a philosophy or deeply held belief that we should strive to reduce the consequences of drug use, and save lives, and that so that we can get people ready to move on to the next phase of their life. But I think here, however, it's clear that it's gone way beyond that intended purpose. Something that might have been relevant in the era of AIDS as a death sentence needs some adjusting in today's world, I would say. We need new investments and awareness campaigns. I commend the current government for their recent investment in prevention and awareness. We need more of this. We need a lot more. Would have loved it, whoever was in power 15 years ago, 20 years ago, 30 years ago. But we need more of this. And we, again, will give credit where it is due. Unfortunately, though, we've also seen how terms, whether it's harm reduction or this other term you've heard in the media a lot lately, decriminalization, have been greatly misunderstood and in some ways weaponized. Again, giving credit where it's due is very, very important. But unfortunately, these things have been weaponized. And so they've been used to promote other policies, sometimes in isolation, not by everybody. There are people in the audience today that probably may disagree with 80% of what we're saying. But we're able to have that respectful discussion. Many of them I've met with in person, we've met with, and we wanted to actually have a dialogue. Today, I think we're cramming in a week's worth of content in about 4.5 hours, so that's our apologies there. But this is the beginning of the conversation, and we do want a conversation. But we've seen how these things can be weaponized. You've heard a lot about Portugal. You're going to hear more, which I'm very excited by Dr. Reeb. Portugal replaced criminal penalties. So they did. We were there when they announced this great announcement of replacing criminal penalties with an administrative process designed to get people the help that they need. But that was only one part of what they did. You could argue it was kind of a small part of what they did, because guess what? People weren't being arrested and jailed in Portugal prior to this policy in any big numbers. So that wasn't the issue. The issue was that they were going to make a massive historic investment in intervention. We don't need intensive treatment for everybody. We've heard people talk about that. I recognize people in the audience who have talked about not everybody needs the heavy intervention of treatment and the expense of that, but intervention along the way as well as treatment and recovery. They set something up called a dissuasion commission. That's the word in English translated from Portuguese. Dissuasion. The goal of dissuasion, not the goal of acceptance, not the goal of making you safe in your use, which is in many ways an oxymoron. Not in a way to perpetuate use either. They stopped public drug use. They made a very big announcement. We will be arresting people in Portugal, and they have, for public drug use and sales, and we're going to go after criminal organizations. But if you need help, we're here for you. And in fact, you may not even know you need help sometimes, but we're still going to be here for you. So it was intervention, treatment alongside replacing the criminal system with an administrative system. It wasn't do whatever you want, whenever you want, wherever you want. And that is how these terms have been weaponized. So I would actually say their success lies in a word that we haven't heard a lot about, which is accountability. And it's not meant to be used in a way that's harsh or cold. It's meant to be used in a way that will get people into recovery versus a laissez-faire approach towards the human beings and their families that are affected by this. We've seen the opposite of Portugal happen in Oregon, just down the road, I guess I could say. In Oregon, unlike Portugal, they didn't make those investments. And it's not surprising then to learn that the drive to move this in Oregon wasn't led by the recovery movement. In fact, the recovery movement was dead set against it, except they didn't have $5 million to compete with the two nonprofits whose stated goal is to legalize all drugs, starting with decriminalization. So when that is how you're starting, it becomes difficult to be successful when there's very little investment in treatment. They thought they were going to fund treatment through cannabis sales, but cannabis sales have been plummeting because the price of cannabis plummets when you legalize it. And so they weren't able to come close to funding the treatment they needed. And this is where we get into this issue of terminology. Again, this issue, decriminalization. It can be confusing, sometimes by accidents, but unfortunately sometimes on purpose, by people with broader agendas. We want to talk about those agendas. We want to talk about terms clearly here, and that's why we're here. And you've heard what's happened in Oregon. I won't go through it, but it was so bad that their Democratic governor, who when running in a very tough race, actually decided to differentiate herself and say, no, I'm going to keep this, but we're going to do it better. But 2 months after she got into office, said, I have no choice but to repeal this. It is a disaster, and everyone knows it. In fact, when they did polling, especially among people of color, who often are the most affected by bad drug policy on either side. Most affected by over-policing and a sort of war on drugs approach, but also most affected by essentially a laissez-faire approach leading to a for-profit approach. Will Jones talked about that. And we only need to look at our history with tobacco, any of our legal drugs, to know what happens when you become a for-profit drug dealer that is able to be on the Canadian Stock Exchange and act in legitimacy. It usually doesn't end well. That's why actually people of color were the most up in arms about what was happening. And so they were forced to repeal it entirely. But what they did was so different than obviously what Portugal is doing. So again, that doesn't mean there isn't room for the proper use of these terms, including harm reduction. And of course we want naloxone. Again, I think Will Jones is the person in this room. There may be some competition, unfortunately, who've administered more naloxone than maybe anybody on a weekly basis. Of course people have different paths to recovery. But this dire situation we are in, I would say, is the result of a massive misunderstanding of the nature of addiction and the nature of drugs. These drugs that really cannot be considered safe any more than driving 40 kilometers over the speed limit can be considered safe. You might get away with it. You might be fine. You might not get into a car crash. You might be okay the first year that you drive recklessly. But when you look at the odds and the statistics, it doesn't look good. Some can do it without consequence sometimes, absolutely. But for a lot of people, it's down a road, no pun intended, that is not good. And the nature of addiction is a brain disease, let me be very clear, and it can be a chronic relapsing one. That's not in contrast with saying that recovery is real. It's another dichotomy we've seen. But this brain disease, unlike, let's say, dementia or another brain disease, it often responds to incentives. And that's something I think we've been afraid to talk about. I have relatives in Kerrisdale who've been here for 50 years. He just celebrated his 101st birthday, and she celebrated her 94th or 5th. I can't keep track. They'll remind me, but I can't keep track. But I can't tell them, and the 94-year-old has dementia, I can't tell her that if she remembers, some minute detail of our discussion today, I'll give her $1 million tomorrow. That's not going to really change the conversation with her, right? But addiction often does respond to incentives. I was lucky enough, and I know he's here in the audience, to speak recently with Judge Tom Gove, who led the Vancouver Community Court for so long. Incredible results, and also, of course, the twins or the drug court. We know that incentives can work. We have to set them up in a compassionate way, right? Not in a way that's overdoes it. That is like a drug court model, but it also means supportive housing. It means supportive healthcare. It means education. It means access to things that you need to live a productive life. But it can't be only a handful of people that go through it every year either. I mean, you have the same problem America has with drug courts. It's a wonderful program, but it's like a little boutique hotel, that there's like 5 in the country. Not really, but that it's just, you need a scale that we don't have, and we need an investment. So we got to start thinking about what happens after the 12th time you administer Narcan to somebody. It's great that you've done that. You should do that. Keep them alive. Get them what they need. Meet people where they're at, absolutely. But what do we do afterwards? And that is something we need to think about. Capacity. It's very easy to say, let's make drug court times 1,000, but if you don't have anywhere for them to go, good luck. It's very easy to say we want to do intervention. If you don't have that warm handoff, good luck. So I'm not saying any of this is easy. It's not. It's hard. It certainly doesn't fit on a bumper sticker, and probably won't fit in a campaign platform. But it's something that we need to think about. So recovery is real. Our friends at the former Canadian Center on Substance Use now just really changed their name recently. But what they have found when they interview people is that recovery is real, and we must believe in people's potential. People want to enter recovery, and so it has good outcomes. And I think sometimes we've led with the idea that people don't usually recover. And so we've started somewhere in a pretty hopeless state. That's a problem. We're not going to get success that way. We're not going to get success when we say, you know, you might be able to recover from this type of disease, but not from that substance use disorder, because it's too difficult. I don't think it's too difficult. And the tens of millions of people living in recovery, including from fentanyl, will tell you that it was hard, but that it's possible. So the reality is, I would say the majority of people can do this. Most people can stop, of course, though some can't. Most kids won't start using drugs, but though some might. And most people can and do quit with incentives, though some might find it difficult. It's not even, like I said, the majority of people that will need treatment. We need to think about all the wraparound that's needed. We need to think about how to intervene productively. What does a warm handoff really mean? Well, you got to have things in place for that warm handoff when you're waiting for people to get into treatment. It's complex. But right now we have to start thinking of the problem that way as opposed to this simple problem. So I think in some ways our policies, and it's not just in Canada, it's not just in BC, but they're underpinned by the assumption that it's too late and there's nothing we can do. And I think it's that kind of hopelessness that is part of the cycle that it almost seems impossible to break from here when you just see the numbers every year. But we are here to say we want to be part of the conversation. We want to be around the table. We want to learn. But we're here to say that there is hope. People can and will recover. Yes, some people will start to use and it will be incredibly hard, but we cannot give up hope on them. So I think the big picture message is, I'll go back to that, but the big picture message is that of course we meet people where they're at, and they're going to be in different places, but we should never be content with leaving them where they're at. That is what this is about. So together with those impacted by addiction joining us as our strength, we think we can help create a world of recovery where it's the norm, not the exception, where our fellow community members thrive. You know, you just look at the criminal justice system in and of itself, 70% of people there, not there for a drug crime, there for a property crime, there for other crimes, have some kind of substance use disorder. That is a low-hanging fruit population that you have a captive audience to intervene on. Why aren't we doing a better job at that? You know, Dr. Humphreys may talk about this later. You know, he and Blair Gibbs, I mean, they helped pioneer the intractable problem of what they call drink driving in the UK, where it's such a part of the culture, but they did so by, believe it or not, exporting and changing it a bit of the culture. A small program in South Dakota that was having so many good outcomes, it was becoming a national model for the Obama administration. And being able to do that in the UK in such a different culture, right? South Dakota and, you know, South London, literally, a little bit different. But they adapted it and did it in a way using these principles that us as human beings can all identify with. So that's what we need to do. But when we lean on these lazy dichotomies, intense police involvement or none at all, you know, a lot of treatment, none at all, we get bad outcomes. And so I think the good news is, there's a lot of good news. Part of the good news is there are things that work, and we're going to be highlighting that. We're not here to beat up on each other about what hasn't worked and then not have solutions. So I'm hoping today we're going to hear about solutions. The good news is British Columbians want to change. In fact, we're releasing, one of the first things we've ever done is this poll today of about 800 people in BC that shows that people actually, they want something different. They want something better. These are people across every single political spectrum, every age, and representative neighborhood and backgrounds. People are wanting something different. They are believing in recovery as the primary goal. It's not the only goal. It's not the only thing we can do. It's the primary goal. And they see this as a huge issue. In fact, they see this as the number one issue that decision makers need to fix, higher than housing, if you can believe it, higher than other issues. And so, you know, we want to be here, again, understanding and being humble as well, that this has to do with a whole society. You know, adding a new drug court in your community isn't going to solve the problem overnight forever. It's part of it, but there's so much else. So we need to start thinking, I think, in a little more sophisticated way, in a little bit more of a hopeful way, and in a way that we actually know what can work for a lot of people. It won't work for everyone, but that should not stop us. And we should demand that we bring this to scale.